Good morning, everybody. Today I will be speaking about nasal, paranasal, and skull-based tumors, diagnostic challenges. This is WHO classification of these tumors, where we briefly classify them as various types. When we come to sinus and paranasal sinuses, it is especially challenging area for various reasons. Number one, it is a very difficult approach for the surgeons to biopsy, as a result of which most of the samples are either necrotic, crushed, small, or filled with blood clot. On the top of that, the tumors are very complex. Their immunophenotype often overlaps. Plus, there is molecular classification. There can be an overlap in the molecular classification as well. So, usual diagnostic workflow is radiology followed by biopsy. Morphology is the foundation of all the tumors. One cannot get up and say molecular wise, this is the finding, so this is this tumor. You have to have a good morphology first, then you do IHC, then molecular workup, and then in MDT you decide the course. In general, when we have undifferentiated neoplasms, the teaching goes, which I tell all my fellows, is sarcoma, carcinoma, melanoma, lymphoma. Germ cell tumors don't form a part of scene here. And if it is negative for pancytokeratin, we consider it as carcinomas, but one always should remember that some sarcomas, especially Ewing sarcoma, synovial sarcomas, can be positive for cytokeratin. And this is just a brief way how to go about it. Like if it's cytokeratin positive expressing squamous markers, it's a type of squamous cell carcinoma, and so on and so forth. Now, the complexities of small round cell epithelial and neuroepithelial tumors of the sinonasal tract. In this particular table, I have sort of taken an overview of what I'm going to talk in the next couple of minutes that I have been given. So if you want, you can take a screenshot of that. You can see the overlap of various IHC markers and molecular markers as well in here. Adamantinoma like Ewing sarcoma, I'm not going to elaborate much, but this is a tumor which is a small round cell tumor which expresses CD99 and NKX2.2. It's a family of Ewing sarcoma. So coming to the very sort of mundane non-keratinizing squamous cell carcinoma, it gets very interesting because of the new kid on the block, DEC-AF2 squamous cell carcinoma. This is an emerging subtype which is defined by DEC-AF2 fusions. Just like CNS in sinonasal tract, we have molecularly defined entities. And what is interesting about this tumor is it has got an exophytic and endophytic growth. These fusions are detected by FISH or RNA NGS. IHC is available but not in India. Some centers, rare centers have it. And there is also an HPV associated squamous cell carcinoma, which is a non-keratinizing. What is important for DEC-AF2 squamous cell carcinomas is to remember the differential inverted sinonasal papillomas and DEC-AF2 squamous cell carcinomas. Both of them have endophytic architecture and inflammatory infiltrate, but in DEC-AF2 the architecture is complex, and if you see in this figure there is cellular disc cohesion. Another differential is carcinoma ex papilloma, but I suppose from a surgeon's point of view, both are carcinomas. Most important is not to either overcall a sinonasal papilloma as a DEC-AF2 or vice versa. So nut carcinoma, I think everybody knows that it is an epithelial malignancy, monotonous cells, and it is defined by rearrangement of nut gene. It is important always to consider this differential, and this rearrangement forms a driver oncoprotein. This is basically small to intermediate size monomorphic cells with abrupt keratinization, and as you can see in this photograph, there is abrupt keratinization. Do I have a pointer here? Don't count this time. This one? Oh, okay, thanks. This, huh? Okay, thanks. Thank you. Yeah, so this is the abrupt keratinization that I am talking about, and these are the primitive cells, and this is the nut protein, IHC. This is just a fish, how the fish looks like. This is DNA probe, and when you see these red and green signals, that means the rearrangement is there. There is addition of a new tumor to this nut carcinoma spectrum, which also shows exophytic papillary arrangement, and it has squamous and basaloid differentiation, and these are associated with NSD3 nut translocation. So one should not confuse them again with DEC-AF2 squamous cell carcinomas. Olfactory neuroblastoma, old tumor, everybody knows. It's a neuroectodermal tumor, and it is, the history gives away when the surgeon says that it is from the cribriform plate and you are getting a small round cell tumor, not much cytologic atypia, expresses neuroendocrine markers and no keratin positivity. Molecular diagnostic pathology, usually we don't take any help. Obviously, there are some molecular changes. There are molecular subtype-based classifications, but they are not popular. This is how the olfactory neuroblastoma looks. You all know and you are familiar with the stage and Himes grading. Olfactory carcinoma. This is interesting, described by Dr. Rupert. And this is a new entity. Very few cases have been described. This is a high-grade keratin-positive tumor which has got high-grade neuroectodermal cells, and they show variable expression of neuroendocrine markers as well as low-grade eosinophilic glandular component. There are ARID1 RNX alterations, and basically in histology one should see this neuroectodermal component, which will obviously express neuroendocrine markers. Then one will have epithelial differentiation, which will be positive for keratin. One has to remember that this keratin positivity is more than 10%, and S100 positivity. Molecular wise, this can have SMARC A4 alteration, ARID1 and CTNNB mutation, but we are not doing molecular testing. It is not necessary for diagnosis. This is how it will look like, glands, and then you have the immature epithelium and the IHC for the same. So olfactory neuroblastoma versus olfactory carcinoma. The olfactory carcinoma is high grade, expresses neuroendocrine markers plus cytokeratin. How does one discern it from small cell neuroendocrine carcinoma? Basically, the concept is that it's the spectrum of a tumor, because number of olfactory carcinomas, they have responded to the same therapy which was used for small cell carcinoma. I found that interesting because sometimes in small biopsies one may not get what is present in the tumor, so one can just say high grade neuroendocrine tumor and stuff like that. Then high grade neuroectodermal cells of olfactory carcinoma, they are morphologically identical to small cell neuroendocrine carcinoma, and they show the same molecular alteration. But basically how one should discern between the two is a keratin positive neuroectodermal tumor which has well developed neurofibrillary matrix. They should be better called as olfactory carcinoma, but at the same time the pathologist should be lucky to have that neurofibrillary matrix in the biopsy. And neuroendocrine tumors, obviously, which don't have any recognizable neuroectodermal component and high grade and no glands, they should be classified as small cell neuroendocrine carcinoma. A subset of small cell are HPV positive, so obviously then you exclude olfactory neuroblastoma and olfactory carcinoma. Large cell neuroendocrine carcinoma, again it lacks the neurofibrillary matrix. Teratocarcinosarcoma, old entity, I think all of you must be familiar with that. Only thing is that for the people who don't know, terato has got nothing to do with the germ cell tumor. It's the immature neural element for which this is called teratocarcinosarcoma. It is a combination of epithelial elements which express the markers of squamous differentiation, mesenchymal component, which can express heterologous or heterogeneous expression, and neuroepithelial component. The markers of germ cell differentiation are absent. This shows SMARC A4, CA4 loss, but as I told you in the previous tumor also, there can be SMARC A4 loss. So it's the morphology that determines if you have the presence of these mesenchymal elements and neurofibrillary matrix, then you go for a teratocarcinoma. This is how teratocarcinoma looks like, which has epithelial, mesenchymal, neuroepithelial elements and loss of SMARC C4. IDH mutated sinonasal carcinoma and sinonasal undifferentiated carcinoma. By definition, a carcinoma is undifferentiated when it doesn't have obviously any squamous or glandular differentiation as well as surface squamous dysplasia. Hotspot mutation in IDH gene is identified in a subset of tumors, and it is important because this IDH mutation is associated with better disease-specific survival and therapeutic implications of IDH inhibitor. It is positive just for keratin markers, and it can be positive for P16. A couple of tumors in sinonasal tract can be positive for P16. It has got nothing to do with HPV. It is a non-specific positivity. And focally, they can be positive for synaptochromo. This is how it looks, and that is IDH positivity. Swiss-Nif complex deficient sinonasal carcinoma, I think this also has become an old entity now. Basically, it's an undifferentiated malignancy, and it is defined by loss of Swiss-Nif complex subunits. Two types, SMARC-CB1 and SMARC-CA4, both are mutually exclusive and having different morphology. SMARC-CB1 is a rhabdoid tumor and SMARC-CA4 is an undifferentiated tumor. And how do you again discern it from teratocarcinoma? SMARC-CA4 because by the absence of sarcomatoid and teratoid tumor elements. This is how these tumors look like. Second figure, this is P16 positivity, and this is lack of INI1. Sinonasal lymphoepithelial carcinoma is a cousin of nasopharyngeal carcinoma, but by the location we call it sinonasal lymphoepithelial carcinoma. EBV associated SSTR2 testing is encouraged because of the imaging and therapeutic implications. It also metastasizes to the cervical lymph nodes, but less frequently, and the prognosis is favorable even if there is cervical nodal metastasis. This is how lymphoepithelial carcinoma will look like. HPV-related multiphenotypic sinonasal carcinoma. This is an epithelial neoplasm which exhibits features of both surface-derived and minor salivary glands elements and harbors transcriptionally active HPV. What do I mean by that is, this has surface squamous dysplasia as well as it has a look of adenoid cystic carcinoma because it has solid cribriform pattern and made of epithelial and myoepithelial elements. Then MIB rearrangements are not there, but it is IHC wise and RNA wise can be positive for MIB. One has to remember that. And it is the surface squamous dysplasia that discerns it from adenoid cystic carcinoma. It is positive for P16, but again P16 here is not a surrogate marker for HPV. P16 negativity excludes the tumor. This is how the adenoid multiphenotypic sinonasal carcinoma will look like, and the diagram is of RNA in situ hybridization. Interestingly, one is getting, not in India but abroad, HPV related tumors, and in oropharynx we know how they arise. The theory of origin of these tumors in sinonasal tract is a reflux. So the guidelines are, if you are suspecting in a high grade carcinoma HPV, you can do direct testing. If you want to do high risk HPV RNA in situ hybridization, you can do. If a tumor is P16 positive, you can do subsequent DNA PCR or RNA in situ hybridization. Various types of tumors which can be HPV associated are obviously non-keratinizing squamous cell carcinomas, baseloid squamous cell carcinomas, papillary squamous cell carcinomas, adenosquamous and HPV associated multiphenotypic. This is an old entity, sinonasal adenocarcinomas. I think all of you must have come across them many a times. Intestinal, non-intestinal, salivary. Interesting thing in them is there was an talk in the USCAP this year about REAH, that is respiratory epithelial adenomatoid hematoma and serous hematoma. They represent a morphologic spectrum for non-intestinal type of adenocarcinoma. I thought this particularly interesting. How do you discern them? Both the benign entities, they lack the complex architecture and infiltrative growth pattern. And the non-ITACs, they have ETV6 NTRAC fusion. So basically, I have learned this recently that they form a spectrum. That's why I included this. This is the immunohistochemical differentiation between the three. Intestinal, as by definition, will be CK, just one slide, CK720 positive, SAT-B2 positive, CDX2 positive. Non-intestinal will be negative for this. Mesenchymal tumors, angiofibroma, glomangiopericytoma, and biphenotypic sinonasal sarcoma. Biphenotypic, all are associated with beta-catenin positivity. Biphenotypic has S100 and SMA positivity. Angiofibroma is positive for AR, and glomangiopericytoma just shows beta-catenin, but one has to consider these differentials also. And TFCP2 fused rhabdomyosarcoma, it's an intraosseous rhabdomyosarcoma which can mimic tumors such as solitary fibrous tumor or sometimes osteosarcoma. So one has to consider this differential when one is dealing with the spindle cell tumors of bone, of sinonasal tract. Any questions? Or I have run out of time?